Very nice introduction, and it's really a pleasure to um, present to this group led by you, obviously, and to present with my esteemed colleague Keith, who has just been a giant in the field. So it's really my honor to do this today. So I'll get right to it. I'm going to talk about the reason that we're splitting this up may be obvious to everybody on the talk, but that just means that we don't really know how to define clinical recovery too well yet, I think, because we have lots of different ways that we can go about trying to do it. I'll talk about symptoms, physical examination, and exercise tolerance, and Keith will focus on cognition, imaging, and biomarkers. So, as Roger alluded to, both Keith and I and Roger were parts of the last Amsterdam Concussion and Sport Group meeting, and the publications were published in the British Journal of Sports Medicine in 2023. And this was one of the systematic reviews led by Doctors Patukian and Broglio on what is clinical recovery from concussion, return to school, and sport. They did a systematic review and medical meta-analysis. And so what in the end, after looking at hundreds of papers within the group, we sort of settled on that a typical time frame for recovery from a sport-related concussion, SRC, was within 2 to 4 weeks, sooner for adults than for children and adolescents. And of course, Dr. Zemek knows this quite well. Although most recover within 4 weeks, there is a percentage, and sometimes a substantial one, probably up to a third when you look at most of the data, take a month or longer to recover. That's now that again, the caveat there is that most of those patients weren't actually treated for anything, which I think we're learning may facilitate recovery for a lot of them. And when you looked at the data back in 2022, there were over 110 different assessment measures in the literature used to determine clinical recovery. So again, just means we aren't very good at it yet, probably. And what are the domains? They're listed here: symptoms, cognition, physical examination findings, biobehavioral, and other categories. This is just the listing of the papers that were sort of reviewed and found to be either inadmissible, acceptable, and then you'll see in green there's high quality, and that's the smallest bar of all of them. So this is an area that's fertile for ongoing research, and I think the Transcendent team is perfectly poised to fill in a lot of those gaps. So what is clinical recovery? Well, you could say it's time to symptom-free or to baseline symptoms, right? Those are very commonly used. You could say it's full return to school or work, depending on who's concussed. Time to unrestricted return to sport for athletes. Normal, what's normal versus prolonged. We'll talk about how that's defined now. But up until Amsterdam, it was quite variable. And then return to baseline function on measures of cognitive function, vestibular function, physical examination, other biobehavioral measures, maybe anxiety screens, things like that. You can look at assessments that are conducted after injury, compare them with group-based norms. That's one way to look at recovery. So there's lots of different ways. I'm going to talk about the physical examination for a little bit, since that's something as a physician I use every day I'm in the clinic. And a number of years ago, surprise, surprise, I put the name Buffalo in there. We came up with a what I describe as a pertinent but brief physical examination for concussion patients. The reason I wanted to be brief is that outside of specialty concussion clinics and things like that, primary care physicians and busy clinicians just don't have a whole lot of time to evaluate patients, or in the ED even. And so you have to design something that clinicians will use. I mean, it's great to have a very comprehensive physical examination that looks at every aspect of concussion, but if it's too cumbersome and too long, doctors simply won't use it. And so being very practical minded, I wanted to put something out there that doctors felt they could use within the time frame of an office visit that they have. And basically, we look at abnormalities that we can see or symptom provocation. And to do this examination in its full form here takes about 8 to 10 minutes. But if you have somebody like you're in an office and a medical assistant or a nurse or a student can do the orthostatic vital signs initially, you can cut that down to 5 minutes and do this examination pretty efficiently. And so it includes things like orthostatic intolerance. And I'm not going to go into the specifics of each one of these, only that this is what we do. We look at changes in vital signs from supine to standing, and more importantly, do patients get symptomatic? The literature shows that this is a very common physiological sign of concussion. Now, it's both a sign and a symptom, I know that, but I view it as a physiological sign of concussion that's very commonly reported, especially in adolescent athletes. Then we look at the eyes very carefully. We do things like smooth pursuits, saccades, convergence of vestibular ocular reflex. We look at the neck because the neck is usually injured in concussion, and if you miss that, you're doing the patient a disservice. And then we look at balance, and there are various ways to do that, from a simple tandem stance to what's called a complex tandem gait to dual tasks, things like that. But this is what we chose back. This got published in 2020, but it was really first published in 2018. So we actually studied this. We looked at various athletes who were injured, and we had a control group. And then we divided the concussed group into those who recovered before versus after 21 days. And what we wanted to see was the physical examination good for differentiating a concussed patient from a control? And also, what did it look like on recovery? And so what we found was, and I'll show some of the data, is that the concussed patients far more often had a cervical injury, which again is really common, and then had abnormalities of these ocular motor and vestibular physical examination components. So 81% of the athletes after a sport concussion within a week had one or more of these abnormal findings, compared with only 5 or 17% of controls. Now, why would healthy controls have quote unquote abnormal findings? Well, when you're dealing with 13, 14, 15-year-old kids, sometimes their neurodevelopment is at a different stage, and they may have bouncy eyes or their balance might not be the greatest. But that's because that's how they are walking around every day. So nothing's perfect, and some healthy people will have quote unquote abnormalities, but if you delve into it a little more closely, they're walking around like that every day. So abnormal vestibular and ocular motor tests were the most discriminating at the initial visit. And when they persisted, they also signaled that this patient was going to go on to have a significantly delayed recovery. So this is the initial examination data, and it's divided into cervical, ocular motor, and vestibular components. The yellow bars represent the combination of abnormalities found in concussed patients, and the red bars are the neurodevelopmental findings and controls. And so this was quite significant in terms of separating out the patients early on. This is when we looked at patients who were 3 weeks from injury. We had some who had not recovered, 11 of the 52 or so. And you can see that in the amber bars, they continued to demonstrate these different physical examination findings, chiefly ocular motor, vestibular, but some cervical. And when you had 2 weeks after your first evaluation or 3 weeks from injury, if you still had these physical examination findings, your recovery was more on the order of 3 months rather than 2 weeks. So this is a pretty powerful indicator. And one reason now, in my practice anyway, if I'm seeing these abnormalities at 2, 3 weeks, I'm treating them right away. I'm not waiting, because if you wait, they are not recovered. Now, very often, well, I don't know how often, but sometimes adolescents, they want to get back to sport, and they're not going to be quite forthcoming about their symptom reports. And whenever someone shows all zeros on their symptom report, I'm a little skeptical. Doesn't mean it's not true, but I make them prove it by having a normal exam. If they report they're feeling fine, but we find a problem with their balance or their eye movements, they're not recovered. And in this study, the physical examination findings correlated with exercise tolerance. We won't talk about that now. So, what were the conclusions? The physical examination is really important for physicians and therapists, obviously, and it distinguished patients acutely after sport concussion from controls. Vestibular and ocular motor findings were the most different, and if they persisted, they were at significant risk of having a delayed recovery. So what does that mean for recovery? Well, one of the most important things for establishing physiological recovery is their physical examination normal? I think I use that all the time. So a normal physical exam helps me decide that, yeah, maybe this athlete's ready to return to play. What about symptoms? So symptoms are important, just that they're non-specific. But it's been shown in virtually every study that the more and the more severe symptoms you have early on, the higher initial burden is associated with days to symptom free and to return to sport. Um, but we used to think that in all cohorts, females had longer recovery. But when you look at the care data from the United States and the DoD, the United States colleges and DoD, at least in college athletes, it looked like when you controlled, for the sport, sex-compatible sports, the recoveries were pretty similar between the females and the males. And in terms of return to learn and return to sport, they really weren't different. Um, so 2/3 of athletes returned to academics and exertion within 14 days. But look, not to competition until about 4 weeks after their injury. So this idea that we used to have that college athletes are different, they recover in a few days or a couple of weeks and get back to sport really quick is not really true. They do take 2, 3 weeks, sometimes 4 weeks to get back. So it's not just that they're necessarily different from other cohorts in that respect. So again, and also in when you looked at age and sex, they were very similar, at least in the college athletes and the military cadets in terms of returning to a sport was very similar for both age and sex. Um, I think Keith will talk some about this, is that, not everybody who's looks physiologically recovered is ready to go back to sport yet. So they have to be psychologically ready. That's kind of a big area now, shared decision making, and that's really important. You want to make sure they're ready to go back psychologically. Um, and again, what affects recovery is the brain they're bringing to the injury. Do they have depression, anxiety, migraines before the injury? They tend to take longer to recover than people who don't have those. But I think what we settled on in the end was that most patients can return to unrestricted sport within a month of injury, and that goes for kids, adults, adolescents, college athletes. Now, 1 month is the typical time for return to injury, and that means again symptoms back to baseline when we're looking at symptom scores. Finally, we're going to talk about exercise tolerance. And I'm not going to go into the specifics of the bike test or the treadmill test, but I want to just show how exercise tolerance can aid you in some decisions you might want to make. So this was a systematic review and meta analysis we did a couple of years ago, looking at all the studies that have used some form of exercise testing, whether it's a bike, a treadmill, and different protocols in both concussed and control populations, and or when athletes were deemed recovered. And when you pooled the data and looked at the sensitivity, if you were exercise intolerant, that is, your symptoms went up on an exercise test, your concussion symptoms, if that's your definition of exercise intolerance, then the sensitivity was just over 94% to help rule in a sport-related concussion. And so what does that mean? That means you've raised the pretest probability that the patient in front of you with symptoms in front of you is suffering from a concussion, and maybe not something else. Maybe they have depression, but their symptoms right now are related to the concussion. They may have a neck injury too, but early exercise intolerance is pretty sensitive for making concussion pathophysiology worse and increasing their symptoms. So that helps you diagnostically. clinicians on this call will understand that sometimes it's not clear if somebody's had a concussion or not. It's not always clear by the symptoms or even the physical examination findings. So that's when I use a treadmill test to try to see if I can raise or lower that pretest probability of disease. Now, to lower it is the specificity. And when we look at exercise intolerance in those who don't have a sport concussion or who are recovered, the specificity is almost 95% to help rule out a concussion or to establish recovery from sport concussion. So this is my point about recovery. It's not made upon one data point. Again, sometimes we want to see symptoms go back to pre-life levels, a good physical examination, and if we're still not sure, prove that you can exercise without any significant increase in concussion symptoms. And if you satisfy those three criteria, at least in my experience, that's pretty good. Now, do I have any data to back that up? So this is a combination of the two randomized controlled trials we did a couple of years ago on exercise versus stretching, where we randomly assigned patients to either aerobic exercise or a stretching placebo program, and then we looked at the recovery over time. When we combine those two cohorts, we have 221 adolescent athletes seen within a week of injury, and many of them, most of them, had some abnormality on the physical examination, as I showed before. So these were patients who were concussed, had abnormalities on physical, and then as part of the studies, the recovery determination was made by blinded sports medicine doctors who were taking care of them, but they were blinded to the group assigned. They didn't know if they were in the aerobic exercise group or the stretching placebo group. And how did we define recovery? Clinically, return to a pre-injury level of life symptoms doesn't mean they're asymptomatic, but they are back to their baseline, a normal Buffalo concussion physical exam, and they're able to exercise to exhaustion on the treadmill without exacerbation of concussion symptoms. So they were declared recovered for those two prospective randomized trials. And when we followed them up 4 months later, all had successfully returned to school and to sport. None of them had recurrent concussions or were not able to attend school or play in their sport. So by that definition, the definition that we use for recovery using those three arms seem to work pretty well in a prospective fashion. So to answer my part of the question, there's a lot of good work going on in biomarkers, but they are not ready for prime time use yet. So we don't have a blood or a saliva test that will tell us somebody's recovered. Be careful of imaging. I see people getting DTIs and fMRIs and SWI MRIs, and I don't know why MRI. They just do it because they have nothing else to do. And surprise, surprise, they never change management ever. I've never seen one do that. So be careful in getting imaging, even in people with persisting symptoms, unless they're clearly getting worse and you don't know why. Use your clinical and physiological information. What's physiological? Physical exam in response to exertion. Symptoms should be back to pre-injury life symptoms on a validated checklist that I've listed here. And for kids, normal school function. That's really important. They should be in school before they're back in sports, and they should be keeping up with their work. Again, a return of that concussion-relevant physical examination, so no vestibular ocular motor deficits. The neck is okay. They're not orthostatically intolerant anymore. And in some cases, higher level athletes, or if you're just not sure, make them prove that they have good aerobic exercise tolerance. Doesn't mean they're ready to go back into a contact sport, but if they satisfy these three criteria, they can now go to the sport-specific part of the return to play protocol. We need more research on other types of exercise, vestibular ocular motor control. That's a different topic. Enough of today. Anyway, that's it for me. I will stop sharing and let the good Dr. Yeates take it from there.
Get my audio on and mess around with my slides here. I think hopefully that works, and you can now see my slides and not my presenter mode. So want to thank Roger and Brenna for inviting me to be part of this. Really love putting this together with John and having looked at the names of people that are in attendance. I feel like I'm talking with a lot of my friends, which is great. So hopefully, whatever I say makes sense and none of you take the blame for anything I'm about to say. So I'm going to cover a variety of different things, get back to symptoms just a bit. So I want to make a few points about that, talk about cognitive testing, imaging, biomarkers, psychosocial and functional recovery, and maybe even a few other things. So, what about symptoms? As John alluded to, we know that the typical recovery course for symptoms involves high levels of acute symptoms with rapid reductions over the first 2 to 4 weeks, nicely documented by Andrea and Ledoux using Rogers 5P data in a publication in JAMA Peds back in 2019. There's some age-related and sex-related variation. We do certainly, at least in Canada, in multiple cohort studies, we've shown that girls have symptoms longer than boys, and to some extent older adolescents, although the age effects are less pronounced than the sex differences. But we also know that despite that overall trend, there are significant percentages, John alluded to, of kids who have persisting symptoms. In a nice scope systematic review that one of my former graduate students led, we estimated that to be about 35%. Now, it's probably a bit lower than in prospective cohorts as opposed to clinic samples because the rate of persisting symptoms is higher in clinic samples, not surprisingly. But in a nice paper that my friend Andy Mayer led, and he's rocking a beard again, I saw, we showed pretty well that how you measure and how you define persisting symptoms really matters. So traditionally in the ICD or in a lot of research, people do a symptom count, how many new or worse symptoms. And while that certainly can work to identify folks with persisting symptoms, it's a bit dangerous because it tends to identify a lot of kids who don't have a history of concussion as having persisting symptoms as well. And if you boil down the paper, essentially what I think we showed is that definitions based on normative data, whether they be reliable change or percentiles based on norms, tend to probably do a little bit better job of not having all those false positives and a somewhat lower than rate of kids identified as persistently symptomatic. So I typically recommend clinically comparing kids' scores on symptom ratings to norms, as psychologists tend to like, rather than just simply looking at how many symptoms they report. There are a number of symptom rating scales available for the use in children and adults. The health and behavior inventory is the measure that my group developed and is embedded in the child SCAT and the code. Jerry Joy has nice measures, the post-concussion symptom inventory, and now more recently, Miriam Beauchamp's developed the reactions measure, which is really well tailored to younger children, particularly preschoolers. In adults, the post-concussion symptom scale is probably the most widely used since it's in the SCAT and the scope, although the river mead also gets used a fair amount in research. At least for kids, there are only two measures that have both parent and child rating versions, the health and behavior inventory and Jerry's PCSI. Very helpful, I'd say, clinically to have multiple raters give you information when you're dealing with kids. So what about neuropsychological testing? Historically, when you go back to the early consensus meetings, neuropsych testing was seen as a cornerstone of evaluation. But that view really evolved over time to the point where we no longer recommend routine baseline testing, particularly outside of the elite level. And don't even recommend that post-injury testing necessarily be required of all athletes. Most recently in Amsterdam, there was a recognition that neurocognitive testing may add value to assessing sport-related concussion. And I'd say this is true of concussion in general, particularly measures of reaction time, because we know that that's one of the more sensitive measures to concussion, but they need to be interpreted in the broader context. What's the concern about baseline testing and its use? One is their lack of reliability. The tests, in most cases, when looked at across time, have a high risk of false positives and false negatives. There's a lack of validity, and it's not clear that baseline testing can be used to predict catastrophic injury or recurrent concussion and necessarily long-term outcomes. But we've shown, as have others, that if you use sensitive, complex measures of executive function that are timed, you can see deficits on those sorts of tests out to 3 months or in some cases even longer, while you don't see measures on more traditional measures of crystallized intelligence like reading and word vocabulary. Also, some nice work that Brian Brooks and Karen Barlow, colleagues of mine here in Calgary, have done, showing that you can find evidence of acute difficulties on neurocognitive testing when it's done in the emergency department, and that the results of that testing, particularly in terms of reaction time, can serve as a predictor of recovery. So I think it's not a question of whether to do neuropsychological testing on folks with concussion, but when, what kind of testing, and why are you doing it? So there's a question of timing, the depth and breadth of the testing, and whether it has implications for management. Back in 2008, a group of neuropsychologists, many of whom names you will recognize, Mike McRae, Vicki Anderson, among them, wrote an article where we tried to essentially recommend an incremental model for neuropsychological testing, where acutely it's a very brief standardized cognitive screening that might be something like the standardized assessment of concussion on the SAC, or computerized testing to get at reaction time. A little bit more post-acutely, there might be an abbreviated neuropsychological assessment that focuses on the areas where we know there's some risk of deficit: processing speed, attention, executive function, and memory. We also recommend performance validity testing, because in some contexts there are motivations to perform poorly on these tests, and of course psychological adjustment. And in the longer term, in some cases, a comprehensive assessment may be indicated, but all of this really needs to be adapted to the patient need and circumstances. What about imaging and biomarkers? Many of you are familiar with the new so-called CDI-M approach to classification of acute TBI that came out of the NIH, NINDS work in this area. Essentially, it's clinical brain blood imaging and modifiers, as they call it. Unfortunately, as John alluded to, really biomarkers are not ready for prime time in concussion, or imaging for that matter. And this systematic review that I had the pleasure of leading for the Sport Consensus meeting basically concluded that diagnosing persisting symptoms, but I would say that this is diagnosing recovery, really continues to depend on symptom report largely, preferably using standardized and validated symptom rating scales. And the research that is available doesn't indicate that any other tool or measure has satisfactory accuracy for determining, diagnosing persisting symptoms, or really telling us whether someone is recovered or not. Brain imaging is useful, and we certainly published a large number of studies out of the ACAP study, both structural and functional imaging. And you know, what's interesting is, in fact, we find few acute differences, although there were some interesting differences in quantitative susceptibility mapping, QSM. What we actually found were later emerging differences that varied by age and sex and symptom status, but overall suggested some evidence perhaps of accelerated aging in the kids with concussion, particularly those with persisting symptoms. But this is at a research level. I'm certainly supportive of using imaging in research, but there's very little indication for imaging. In most cases of concussion, we have good prediction rules that allow us, pre-CARN and the Canadian rule that allow us to predict who should be imaged, and it's a very low percentage. And as John says, rarely affects clinical care. I'm a big believer in the importance of psychosocial recovery. We've shown, and others have shown, that psychological resilience is an important predictor of recovery. In fact, psychological resilience takes a hit on average after concussion. Kids with concussion feel less resilient immediately after their concussion, and there is some recovery over time. So paying attention to someone's resilience may be important in terms of trying to understand whether they've recovered. John also alluded to the nice work that's being done more recently on psychological readiness, which is an individual's state of preparedness to get back to their daily activities. And there's a nice scoping review, narrative review that was published in 2024 on this topic. Jeff Caron, who's at the University of Montreal, and some of you may know, has done some really nice work in this area. So we really need to think not only about whether somebody symptomatically recovered, but are they ready to get back to the things that they want to do, whether it be sport or school or work. We've also begun to see increasing evidence that peer relationships and social support play a really important role in whether someone is ready to or able to go back. There are multiple studies now, some of which I've listed here, that show that pre-existing peer difficulties actually predict longer recovery, and that post-acute peer and social support is a predictor. Most recently, in a paper we published in Journal of Neurotrauma, interestingly, post-acute loneliness and post-acute social support were among the strongest predictors in a multivariable psychosocial model, predicting symptom trajectories. And what's interesting about this is these were particularly strong predictors of long-term persisting symptoms, 3 and 6 months. In contrast to something like acute symptom count in the ED, which is a strong predictor of acute trajectories involving higher levels of symptoms, but doesn't predict necessarily as strongly the 3 and 6 month persisting symptoms. There are a number of tools that allow us to assess recovery across multiple domains, because I don't think there's any single domain that takes precedent over others. I really like the BCPE, the Buffalo Concussion Physical Exam that John reviewed. And of course, the SCAT and the SCOTE are available now. SCAT's been around for a long time, does a nice job of getting at symptoms, coordination, oculomotor screen, balance. It's been updated to include more in the way of gait. We now have the SCOTE rather, that John also played a role in, where we're able to do a more extended examination. These can be modified outside of the sport context. The visual-vestibular exam that was developed by the folks at CHOP is a really nice way of getting at some of the visual vestibular issues in children. There is the modified VOMS on the SCOTE. I would just caution people. Noah Silverberg's done some nice work to show that symptom provocation is driven as much by psychology as it is by anything biological. And in fact, if you look closely at his work, it's really funny to me that one of the most strongest predictors was a symptom provocation measure that really had nothing to do with the vestibular system or visual system. So we need to be a little bit careful about what we think the VOMS is actually measuring. And then in the psychosocial area, the SCOTE now provides measures of anxiety, depression, sleep, self-efficacy, which is much like resilience, and fear avoidance, which Noah also has shown very strongly as a predictor of persisting symptoms, but also is relevant to trying to determine whether somebody is ready to go back to activity. I think it's important not to forget functional recovery. We almost always talk about return to learn, school, and return to play, increasing attention to return to work. But I think given the evidence we now have for the importance of peer relationships and social support, we also have to pay attention to whether somebody is back at their prior levels of social participation. For kids, are they hanging out with their friends? For adults, are they hanging out with their friends? Are they going out and doing things? Or do they feel very isolated and lonely? So what haven't we talked about? We haven't talked about a variety of what I call fancy device-wise measures that are available for measuring cognition, balance and motor, visual, vestibular, oculomotor function, and other domains. I haven't talked to them in part because I don't know that we have necessarily strong evidence they add anything over more easier to do and less costly measures of the same domains. I would say that headache is a really important variable all by itself that we need to pay attention to in terms of understanding recovery. Preliminary classification of headache into migraine and non-migraine can be made pretty simply, and a variety of studies have shown that migraine type headache is associated with a much higher risk of persisting symptoms, and we really need to address migraine. Another variable that I think we don't pay enough attention to in terms of recovery from concussion is pain. It's really a neglected predictor of recovery. It's one of the strongest predictors we found of persisting symptoms, surprisingly common, and many kids complain of pain after concussion that is not just because of headaches. So I would suggest that pain should be queried routinely in the management of concussion. And finally, I'll just mention that complete or optimal recovery takes longer than some of what we define just based on symptoms. This is a nice paper that Miriam Beauchamp led out of our ACAP data, looking at optimal functioning. We defined based on 11 variables covering motor physical, cognition, social emotional, and resilient support domains. And what was interesting is that we found a sex difference, so the girls took longer to reach sort of optimal recovery compared to kids with orthopedic injury. And in the girls, they were still still recovering in terms of optimal recovery 3 months later on average. So we know that there's even others that have even more protracted recovery. Boys did recover more quickly, so that by 3 months they were on average not distinguishable from the kids with orthopedic injury. So recovery is a complex construct defined in a multidimensional way. That's why I object in many cases in clinical trials where we're forced to determine a primary outcome of recovery, because I don't think we actually can do that very well. But at a clinical level, I think we now have tools to assess a more multidimensional approach to defining recovery.